Now let us talk about the visceral leishmaniasis co-infection in HIV infected person. HIV infected persons. Okay. We have already discussed that the HIV and visceral leishmaniasis co-infection is deadly because both of them affects the host immune system. Okay. Visceral leishmaniasis behaves as an opportunistic infection in HIV-1 infected person. In HIV-1 infected person, the visceral leishmaniasis behaves as opportunistic infection. Okay. And in the persons who are HIV infected, the risk of visceral leishmaniasis development is increased by several fold. Okay. These co-infected persons will show the classical sign of visceral leishmaniasis. Classical signs of visceral leishmaniasis, but atypical features. Because in HIV and visceral leishmaniasis co-infection, there is already loss of immunity due to HIV infection. So the immune responses seen in the visceral leishmaniasis cannot be seen. Second is the involvement of unusual anatomic features, locations. So there is classical sign of visceral leishmaniasis, but the atypical features, unusual anatomical locations are involved. Example, there is infiltration in the skin, oral mucosa, GI tract, lungs, and other organs. And serodiagnostic tests are also negative in 50% of patients. It is negative because of the loss of immunity. And these leishmania are recovered from the unusual sites, like from bronchoalveolar lavage and from Buffy code. So in case of visceral leishmaniasis and HIV visceral leishmaniasis co-infection, the examination of Buffy code and the BAL, that is bronchoalveolar lavage, can provide a diagnostic information on visceral leishmaniasis. Okay. In other cases, we used to examine the splenic smear and the bone marrow smear, but in case of HIV and visceral leishmaniasis co-infection, the blood Buffy code can be examined for visceral leishmaniasis. Treatment of HIV visceral leishmaniasis co-infection. HIV visceral leishmaniasis co-infection is treated primarily by the combination of antiretroviral therapy and anti-leishmanial therapy. Because if the CD4 plus T cell count is greater than 200 per ml, the frequency of relapse is less. So if we can restore the CD4 T cell count, then the relapse will be less, and this CD4 T cell count can be restored by antiretroviral therapy. So if there is combination of antiretroviral therapy with the anti-leishmanial therapy, then the CD4 T cell count is increased, which will decrease the relapse of visceral leishmaniasis. The anti-leishmanial therapy uses amputation B, which is the drug of choice, both for primary treatment as well as for treatment of relapse, Amputation B is delivered at a dose of 40 mg per kg on days 1 to 5, 10, 17, 24, 31 and 38 days. And this regimen is approved by FDA. But most of the patients experience the relapse within 1 year. If liposomal amputation B is not available or not accessible, then pentavalent antimonial compounds and amputation B deoxycholate can also be used. In the Mediterranean basin, the HIV-visceral leishmaniasis coinfection is decreasing due to the introduction of highly active antiretroviral therapy, whereas in Asia and Africa it is increasing. HIV-visceral leishmaniasis coinfection is increasing. Okay. Secondary prophylaxis can be done by pentamidine or lipid amputation B, and they have shown to delay relapses. However, no regimen has been established as optimal. Thank you.